Today we're talking about the calcium scan, or calcium score, and we're going to cover 5 super common myths about the calcium score. Let me know how many of these you find surprising. I'm guessing for most people, it's going to be most of them. First of all, what is the calcium scan? It's basically a CAT scan, works by X-rays. You lie down, they slide you into the scanner, and it basically takes an X-ray image of your chest, and it can show the calcification in your coronary arteries. So the arteries feeding blood into your heart muscle. In the end, you get a calcium score, which is basically a quantification of the amount of calcification in your coronaries. It's a quick test, takes about 10-15 minutes, and it costs about $100, ballpark, depending where you go. And the calcium score can be useful. It can give us an idea of how advanced the plaque in your arteries, in your coronary arteries, is. So the first myth about the calcium scan is, I have a calcium score of 0, so that means I have no plaque. I see even medical doctors sometimes saying this on social media. That's a big misconception. A calcium score of 0 doesn't mean no plaque, because the calcium score doesn't measure plaque per se, it measures calcification. And calcification happens pretty late in the disease process, in the plaque formation process. So it's possible for me to have a calcium score of 0 and have what's called soft plaque, non-calcified plaque. And actually, in some cases, you can have plenty of it. Here's a striking example. This study looked at people who had lots of plaque. The diameter of the coronary artery was reduced by 50% or more. So they call that obstructive coronary artery disease. Out of those people, 14% had a calcium score of 0, but it varied a lot depending on age. For older people, 70 years old or above, only 5% of people with that level of obstruction had a calcium score of 0. But for young people under 40, it was 58%. So most young people with obstructive coronary artery disease with a lot of plaque had a calcium score of 0. They concluded that the diagnostic value of a calcium score of 0 was small in younger patients and greater in older patients. They also followed 24,000 of these people with a lot of plaque for 4 years. And about 30% of the heart attacks or death that happened in that group happened in people with a calcium score of 0. Don't get me wrong, if you have a calcium score of 0, the odds that you have obstructive CAD, obstructive coronary artery disease, that you have that much plaque are very low. It's in the single digits. It just doesn't rule it out. Because in people who do have substantial amounts of plaque, especially if they're younger, calcification may not have had time to develop. So a calcium score of 0 is good news. All else held equal, it's a marker of lower risk in most cases. It just doesn't guarantee immunity, doesn't guarantee safety. That's the take-home message. Hope that makes sense. Also good to remember, we can have plaque in many other places besides the coronaries. In this study, they found that out of people with a calcium score of 0, 54% had plaque in the legs or in the carotids leading up to the brain. To put it succinctly, a calcium score of 0 is desirable, but far from perfect. So think of calcium as the tip of the iceberg. It's a marker of advanced disease. If you can see it, it's a signal that there's a lot more under the water. If it's not there, if you can't see it, maybe there's nothing, but there could be. There could even be a substantial amount, and it could even be growing fast. The calcium score can't rule that out, especially at an early stage. Okay, second myth or misconception, a calcium score of 0 doesn't even mean that there's 0 calcification. It means no detectable calcification. The scan picks up calcification above a certain size, but not smaller calcium spots. In this study, for example, they found that about 4% of people with a calcium score of 0 had some calcification that they could see with more sensitive methods. Okay, but this is a little academic. Is there calcification or not? Even is there plaque or not? At the end of the day, what we care about is risk. What's my risk of having a heart attack or a stroke, etc., right? The rest is kind of details. So let's talk risk. The third myth is that a calcium score of 0 means no risk. I see people saying this all the time. I have sky-high LDL cholesterol or ApoB, but my calcium score is 0, so I'm completely safe. That's like saying my glucose is sky-high. I have raging diabetes, but my toes aren't tingling yet. I still have all 10 toes. That's good to know, but it's a very low bar, and it doesn't guarantee long-term health. These authors spell it out. Clinicians should clearly communicate that a score of 0 does not imply that risk of an event is 0. Event means heart attack, stroke, etc. Or that the patient has 0 atherosclerosis, so 0 plaque. And a calcium score of 0 may provide a false sense of security. The key mindset here is time frame, short term versus long term. A calcium score of 0 indicates very low 5 to 10 year risk of an event, like a heart attack. About 1% chance over the next 10 years, according to some studies. Okay, 1% chance of having an event like a heart attack over the next 10 years. How relevant is that? It depends. If I'm 80 or 90 years old and I have a low risk of a heart attack in the next 10 years, that's good stuff. But for example, I'm 45. If somebody tells me that my risk over the next 10 years of having a heart attack is very low, okay, that's good to know, but I wasn't counting on it. I sure hope not. What I really want to know is the next 30 or 40 years. It's explained here really clearly. Preventive cardiology has begun looking ahead to lifetime risk rather than 10 years for calcium score and most risk calculators. Now, I recently discussed exactly this issue with Dr. Tom Dayspring. Tom is an internal medicine and lipidology specialist, and here's what he had to say.
So I think once calcium is there, that's one of these big indicators to me. You are the person I'm going to blow ApoB and try and make it 40. But if you come to me and your ApoB is whatever, and you say, but I did a coronary calcium and it's normal, I would say, okay, so here's the decision to make. Are you worried about what's going to happen to you in the next 10 years? Or are you worried what's going to happen to you at ages 70, 80, 90? Because if you are, then we're going to start maybe trying to lower your ApoB regardless of your calcium score. But if you're just saying, no, am I going to have a heart attack in the next 10 years and your CAC is 0? I would say no. And therefore, do I want to lower your ApoB? It only depends if you're worried about longer term events of atherosclerosis. Then you're always going to lower ApoB. So you get into that question. So, these people go on their ketonic diets and send ApoB through the stratosphere. They go get a coronary calcium and it's 0. And they say, God, thank God I don't have to do anything. And you're playing that game again. At what point is that ApoB going to harm you? Or is your wishful thinking going to come true and it's never going to harm you? And you can play that game in yourself. You're the only one who can make that decision. No matter what Tom Dayspring tells you or some other advocate of ApoB is meaningless tells you, you can decide yourself.
So the key takeaway here is that the value of the calcium score hinges heavily on the age of the person. Oftentimes when I see someone on social media saying, my cholesterol is sky high, but I have this calcium score of 0, so I'm totally relaxed. And by the way, I'm 33 years old. There's a misunderstanding there in terms of this temporality and the long term. A calcium score of 0 is the norm in young to middle-aged people. For example, in the Cardia study, among people 36 to 42 years old, 90% had a calcium score of 0. And in the MESA cohort, for people a little older, 45 to 54 years old, 73% had a score of 0. So even up to mid-40s, mid-50s, most people have a calcium score of 0. And that's for Western populations, right? Where cardiovascular disease is the #1 cause of death, and it's incredibly common. So it really drives home this idea that a calcium score of 0 is what's expected. It's not a high bar. Unless you're significantly older, if you're 70 or 80 or something like that, then it starts to be more reassuring. Put in simple terms, a calcium score of 0 in a younger individual is normal and expected, but it has a lot more power at an older age. Just like fine wine, the value of a calcium score of 0 increases with age. I love a good analogy, and that's a pretty good one. Okay, fourth myth or misconception is I'll just keep an eye on my calcium score, and if it shoots up, then I'll make some changes. Remember, calcification is a pretty late manifestation. It's a marker of a pretty advanced stage of the plaque. So it's not a warning that the disease might progress. It's a diagnosis that it already has. By then, you're basically doing damage control. Yes, there's still several tools to manage risk, to reduce it, to prevent it from rising further, pharmacological and lifestyle. But the real bang for our buck is in preventing the plaque from forming in the first place. In other words, plaque calcification is a late event, so it does not accomplish early pre-plaque detection. The goal being to prevent any plaque from forming in the first place. Now, of course, the amount of risk that I'm willing to tolerate is a personal decision. It's for us to decide, for each one of us to decide with our doctors. Just be aware that waiting for the score to go up to then address risk factors is largely missing the boat, the window of opportunity. So as long as it's an educated decision and people are aware of all the factors. There are more sensitive imaging methods that measure soft plaque as well, like angiography, for example. But it is more expensive and more invasive. Here's Tom going over it.
You also know, Gil, that there is a much more intensive imaging procedure of the coronary arteries where you just take a needle and you inject a dye. You don't stick a catheter up in somebody's heart, but you inject a dye that can show up in an X-ray. And it's called CT angiography. And that can show plaque that is not yet calcified. It might show, God, you got plaque, you got an 80% lesion there, but it's not calcified. Maybe you got a lot of smaller lesions that are not calcified. But how do you know they're not going to rupture tomorrow and cause a thrombus that will occlude your artery? So CTA would be a much better test to do, except it's 10 times more expensive. Radiation exposure in the wrong hands can be way more. In the right hands, it's not very much at all. So, but it's super expensive. Your insurance company might not even cover a $100, $200 coronary calcium. They're not going to cover a $1,500 CTA. So there are other issues. If everybody in the world could get a CTA at a certain age, fine, but that's never going to happen, of course. Most of the time, CTA is done investigating people with chest pain.
Okay, fifth and last myth is that the calcification in the artery is the cause of risk. Calcifications don't cause risk. They're a marker of risk. They're an indicator of how advanced the disease is. The more plaque someone has and the longer they've had it, the more likely that there's calcification. But the calcification itself is not the problem. In fact, it can sometimes be a benefit. Calcification is part of the scarring process of the artery, and it can actually make it less likely to rupture and cause an event. In fact, plaque disruption and thrombosis tends not to happen in calcified segments, but in adjacent areas. So, calcium is not actually the causal mediator. It's not what causes the problem itself. I hope this isn't too confusing. In general, more calcium is a signal of higher risk because it's a marker of more plaque and more advanced plaque underneath, just like the iceberg image. But you could have something that raises calcium and doesn't raise risk, or even that lowers it, right? A little odd, a little counterintuitive maybe, but hopefully it makes sense now that we understand the calcium is just a marker of disease progression. The most poignant example of this are statins. Patients on a statin sometimes see an increase in their calcium score, yet their risk of an event is going down. That's because statins have a plaque stabilization effect that can involve calcification. Here's Tom Dayspring again explaining this much better than I ever could.
Another thing pertaining to calcification that confuses a lot of people is that statins can increase calcification a little bit, right?
Indeed, there are studies showing that. But in all trials, what do statins do? They reduce the incidence of heart attacks. So statins, you can make the case, are stabilizing existing plaque. They're scarring it off. So calcium appears, but that is unlikely to be a plaque that's going to rupture and induce a clot that's going to send you to the CCU. So never would you stop a statin because a coronary calcium score is increasing. You judge statin efficacy not by follow-up imaging, but by ApoB. That's what tells you is the statin working or not. Look, when they first came out, I had people who would run and get them every year. I didn't advise it, but cardiologists at that time did. That was a waste of money and time because we know the statin trials show, especially if your ApoB is going down, you're going to have less heart attacks regardless of your calcium score. So right now I see people are sort of recommending, well, if you get a calcium score maybe you should repeat it in anywhere from 4 to 6 years, because you can maybe, especially if it was 0 to begin with and it's now positive, but even say it was positive, but it goes up astronomically high. Is that a worry? Maybe that would lead you then to a CTA or other better evaluation of your coronary tree. But you don't make statin decisions per se only because of what might be happening to a coronary calcium score.
So bottom line, a calcium score has prognostic value. It can help determine what someone's risk level is. And it's especially relevant in 3 situations. A young person with a score that is not 0, that's a red flag. An older person with a score of 0, that's reassuring. And the third case is in borderline situations. Maybe someone who has some risk factors, but it's not clear if starting medication is the right move, or the person would rather not. In those cases, a calcium scan can help tip the scales one way or another. It can be a decent tiebreaker. Here's Tom Dayspring again.
The guidelines currently suggest if your LDL cholesterol is above a certain level or your ApoB is above a certain level, you are in a group that should consider statin therapy. But if you are totally anti-drug therapy, things that would twist your arm to say you better go on a statin would be a positive coronary calcium or the presence of LP(a) or the presence of diabetes. Then you always go on a statin. So that's how coronary calcium tests can be used. Any tests are great tests if you know how to interpret them and use them, and then explain it to the patient, how it helps us solve maybe part of the problem, but atherosclerosis is a long-term problem.
A great resource that just came out recently is a 1-page primer on the calcium scan. It's illustrated, written in a way that anybody can understand, and it covers all the basic ideas you need. And it's completely free access, so I'll link that in the description below. Hope this information helps. Let me know your questions in the comments. Take care. I'll catch you next week. Bye-bye.